Thank you for the wonderful introduction. That sounds like someone else, not me. But thank you very much, and I appreciate the opportunity to come here to speak with you all today. I speak with most of you a lot, and so thank you for putting up with my talk today. Anyway, we'll be talking on PrEP and women, or I will be, and I welcome your questions. Although this talk is focused on our cis women, I want to really stress the importance of having these similar discussions and conversations around our transgender sisters. So just in effort to disclose my disclosures, I am a consultant for Gilead, and I also receive research support from Janssen Therapeutics. So as we begin this discussion, I want you just to think about these three patients. And these are kind of some of the typical patients we see at MCA clinic. So a 27-year-old pregnant female with an HIV-positive partner tested negative in her first trimester of pregnancy, but at baby's second week follow-up, mom noted to be positive and baby tested positive as well. 17-year-old female victim of commercial sex exploitation who was referred from juvenile hall tested positive for gonorrhea, chlamydia, and HIV all at the same time. And a 53-year-old female single dating with 2 partners within the last 2 years and tested HIV positive at a routine physical exam. So if we look at who are the women at risk for HIV, you saw this, You saw this last month when the biomedical intervention team presented on PrEP. And we focused on some of the high-risk populations that the intervention team is focusing on. But also of alarming in this chart is the lifetime risk for African-American women and Hispanic women. These are quite alarming. And when I saw these results last year, that the CDC published these last year, I was actually quite alarmed. Of course, this fits me right here, and a lot of my patients are in here, and in comparison to white women here. So this risk is true and real, and it's why I do the work that I do. If we look at the latest data that the CDC has for 2015, HIV incidence cases, again, just mirroring what we saw on the left side in terms of women at risk, African-American cases, new cases per 100,000 population. You can see the risk in the United States is 26.2 per 100,000 population, and in California, 18.5. And so you can see that California mirrors the rest of the United States in terms of women at risk for women with new cases of HIV in 2015. So the majority of women who get HIV get their HIV transmission from heterosexual sex. And while most risk factors for HIV include the ones that everyone typically knows and the ones that we talk about, IV drug abuse, men that have sex with men, these don't apply to most of our women, and certainly most women don't know if it applies to their partners. And so that's one of the important things in terms of recognizing women at risk, as women recognizing that they're at risk. And I think that is one of the biggest challenges in terms of recognizing and getting women tested, is really just women recognizing themselves that they are at risk for HIV. Also, of course, the stigma and fear and discrimination associated with HIV keeps women from getting tested, and also the homophobia associated. And these are cultural things as well, right? There are different things in the African-American culture and the Latino culture that we just don't talk about, discuss, do, and so we don't test. And so these are all important things that put women at risk. Young women are more likely to be high risk for HIV because they're more likely to have more partners. They're also more likely to have older partners who are more experienced, so it puts them at risk as well. They're more likely to have STIs, which facilitates HIV transmission. And because they have immature reproductive tracts, their cells are more likely to become infected with HIV upon exposure. Older women also are at risk, and mostly because they tend to be unaware of their partner's sexual activity, and they usually don't ask. It's kind of the don't ask, don't tell sort of philosophy here. In addition, older women are more likely not to use condoms with their sexual intercourse, and that's mostly because they're not worried about getting pregnant. And so the messaging has to be focused not just that condoms prevent pregnancy, but they also prevent STIs. And most people know that, but older women don't tend to think about that. So there was a study done in these high-resource or high-risk areas here in these 5 states here. And this study was a little bit old, so it's done back in 2009, 2010. And the ISIS study was trying to identify what risk factors in women put them at risk for HIV. So they looked at a group of women, and to be eligible for this study, these women really had to have met some eligibility criteria, meaning they were negative and they had unprotected sex within the last 6 months. And so they were trying to describe risk factors that impacted women's risk for HIV. And what was interesting in this study was that on initial entry into the study, 1.5% were already tested positive. So these women had never not known that they were HIV infected, and they were already infected at the entry of the study. So again, more education in terms of women being tested and knowing that they're at risk. They didn't realize they were at risk, but 1.5% were already tested. And the annual incidence in this group of women here was 0.32%, and this is much higher than the CDC had originally estimated for risk of women in this population. The majority of these women were African American, about 88%, and the risk was associated with substance abuse, older age, so compared with 18 to 26-year-olds, women that were older than 27 and up were more associated with to be HIV positive, and then the HIV diagnosis of the partner. So certainly knowing your partner's status is important. So I'll go through some of these trials, and I don't want to spend a ton of time on the trials of PrEP in women because most of you have heard about them, but these 2 that are on this slide here are really some of the early trials in women that really had no effect. And so this is quite concerning because these studies did use Truvada, and these are heterosexual women that participated in these studies. These were all done, both trials were done in countries in Africa, using varying degrees of Truvada and sometimes topical Truvada in this case. But again, there was no effect in terms of decreasing the incidence of new HIV infections. And so this caused quite a bit of alarm because this was the only drug that we have on the market for prevention of HIV. And certainly we needed it to work for women. And so we were all quite concerned, and particularly in African countries, most of the transmission is to women and heterosexual women. So we really did need something to help prevent the spread of HIV in those countries. Moving on, we came to these other studies that did show some effect. And so these were extremely important to follow up on the first 2 trials that I told you about. So there's Partners PrEP TDF2, this was a demonstration project. This one was also a phase 3 randomized double-blind study, and looking at Truvada in heterosexual discordant couples. And so this one was really important because the positive partner was not treated. Only the negative partner was given Truvada. And so there were, these were high-risk couples, 4,700 couples, 38% were HIV negative female. And they used either Truvada or tenofovir versus placebo, and there was a great response. So in those patients that took Truvada, there was a 67%, or tenofovir, there was a 67% reduction, Truvada 75% reduction. And if you looked at those patients that participated that had detectable tenofovir in their blood, the reduction was 90%. So this was really fantastic. It showed that if people took the med, it did work. And so I think that was the important lesson learned compared to the other 2 studies, and I'll talk about some of the limitations in the first 2. Again, in the TDF2, it was a randomized double-blind placebo trial comparing Truvada versus placebo, 45%. So these were just heterosexual people that came to participate to protect themselves. There were 45% females, majority of them were unmarried, and you can see the age range of this group. So a young age range here. It was a smaller study compared to this size here, But again, you saw a 62% reduction in HIV. So this is kind of proof of concept that this medication does work to prevent HIV. And then, of course, everyone knows about the landmark study of HPT N052, and this is the treatment as prevention, essentially, in terms of taking heterosexual couples and giving combination ART to the person that is infected and seeing a 96% reduction in transmission to the negative partner. So these were all landmark studies that really are driving what we do today and support what we've been doing for a long period of time. HPTN 069 is relatively newer in the sense that it's giving us an alternate regimen other than Truvada, because we do need more than Truvada in terms of looking for medications for prevention of HIV. So this one was looking in women. So there are two actually studies. Oh gosh, sorry about that. I'm going crazy with this thing. There's this study was a offshoot of the original study. And that there are two cohorts. There's a cohort of women that were 188 patients in this study, and there also was a cohort looking at MSM as well. And so in this cohort of women using Maraviroc, and it was 3 different regimens of Maraviroc compared to Truvada, it showed that the Maraviroc-containing regimen was safe, and the adherence was pretty good at 60 to 65%, and there were no new infections in the women's group. In the men's group, there were some infections, but in the women's group, there were no infections, and there was a low number of STIs in the women's group. So again, this is another regimen that is potential to really serve for PrEP, although it's not approved for it now. And then the IPREC study was also another study that I put up here that included transgender women in the trial as well, again looking at oral Truvada, and showed a 44% efficacy. So all in all, we have studies that support use of PrEP in women. We have the 2 most effective studies and landmark studies that show that it does work. And why it didn't work in the other 2 studies, the first 2 studies really was about determining who was at risk and women really recognizing whether they were at risk or not. In the Partners PrEP study, women tended to be a little bit older. They were all in committed relationships, and they knew their partner had was HIV positive, and so you may be more motivated by that in terms of taking the medication. In the TDF2, it was a small study size, and so it's kind of hard to make big generalizations, but it supports everything else that we know from the Partners PrEP. And then, of course, in 069, the Maraviroc, women were really motivated for that study because of their own personal motivations to participate in the study, as well as they like the adherence cues and reminders. And so thinking about ways that we need to help people stay on PrEP, because one of the challenges of PrEP is people taking it daily. And how do you remember to do that? What was also interesting in the HPTN 069 study was that there were few concerns from the women about HIV stigma and side effects. And we always are worried and concerned about so much stigma preventing people from accessing care. But certainly in this group, these women were motivated enough and they weren't too worried about, they didn't report that as a concern for them. But what was really interesting to me in this study is after the study, the women had mixed views on whether they were going to continue to be on PrEP. And only 24% of the women in the study really felt that they were concerned about acquiring HIV. And so again, that goes to, studies. Some people are motivated to participate in studies for whatever reason. And so that's why doing the real world experience studies in terms of translational research and demonstration projects really helps us figure out how does this really work in the real world, because people are motivated by studies for different reasons. All right, so again, I told you it wasn't effective in FemPrep or Voice. Mostly the women were young age. 59% were under 25 in these 2 studies. And drug levels were only detected, meaning the tenofovir drug level was only detected in 21% of the young girls versus 54% in the older women. So if you don't take it, it does not work. And that's why they saw such a high rate. And then the other interesting thing for this is, again, the perception of your risk. Most of the women in these studies did not feel that they were at risk for HIV. So if you don't feel that you're at risk for something, why are you going to take something that you don't feel you're going to benefit from? So again, it's a lot of education that needs to be done. So even though those 2 studies were technically failures in terms of what their outcome was, they actually taught us a lot about women and PrEP and what women want, and maybe women don't want to take a pill every day, or maybe women don't want to use a microbicide. And so I think what ongoing and what continued studies are trying to really show is what will work for women, and it's the same for other populations as well. What will people do and take in order to prevent HIV infection? And so there's some ongoing studies, and a lot of studies are being done here right in Los Angeles, and so certainly, you know, there are a lot of research institutions that are participating in studies. There's HPTN sites here in Los Angeles, and so we need to be aware of what studies are and how, and to encourage folks to participate in the studies. The AEGIS study is looking at test messaging and drug level monitoring and adherence in terms of outcomes using Truvada for prevention of HIV transmission in women. So this study is still enrolling as well. So again, another important, in terms of what works in terms of keeping people adherent to the Truvada. There's all these different studies with alternate regimens, promising studies using injectable cabotegravir. I'm really excited about this. And again, focusing on populations that are at risk and really trying to separate and get good data on these high-risk populations, because it's really difficult from the previous studies really to separate out gender in terms of particularly MSM and transgender women, really separating and analyzing those data separately versus lumping these populations together. And I think we get more information if we really can understand the population that we're really trying to improve risk of infection. And then the immunotherapies is also a promising drug. This is VRC01. It's a monoclonal antibody, and it actually has ongoing studies as well in all populations. So these are all different meds that are being looked in, injectables versus orals versus monoclonal antibodies that you may only have to give every 2 months or so in terms of looking at new medications for preventing transmission. Now moving on to conception. So this is a big part of what I do as well, and relatively newer part because these guidelines came out in 2014. So the U.S. Public Health Service issued these guidelines to help, since Truvada was approved for prevention, to help serodiscordant couples. And so serodiscordant couple is one who's positive and one is negative. These guidelines are really to help when you have a positive male partner with a negative female partner, try to safely conceive having a baby because people want children. Not sure why, but well, I have two. Anyway, they're a lot of work. Nonetheless, these guidelines came out in 2014, and since then we've been trying to help women do this and conceive safely. And both the FDA has labeling information for this and the Truvada package insert, and also the perinatal treatment guidelines also permit this use. And so when people have questions and concerns about it, you know, you can always refer them to the guidelines, but certainly it needs to be, people need to be experienced and ready to counsel patients in this area. And preconception counseling is just a huge part of this because this is not no risk. I told you what the risks were in terms of PrEP use in women and the decrease in transmission, up to 96% of people are using treatment as prevention as well. But we don't, I think whenever I see a couple like this, I mean, it just makes me nervous, right? The risk is not zero in terms of transmission. And not only are we talking about trying to keep a mom from being pregnant, but we're also trying to keep a baby, I mean, not pregnant, HIV, but we're also trying to keep a baby from getting infected as well. And so these are two lives that you're trying to prevent HIV infection in. And so we spend our preconception counseling appointments tend to be about 2 hours. And this is kind of the luck, you know. People are concerned and worried when they're making this decision on if they're going to have a baby or not, or what's the risk to their baby if they're already pregnant by the time they come to us. And so again, we offer the PMTC services, which is a really critical component when you're offering PrEP in this setting, is to be able to have access to prevention of mother-to-child transmission services. Assisted reproductive services is always very safe. Hospitals and private insurance doesn't cover this. And so this is expensive, particularly for the patients that I have. that I see, they don't tend to go this route, but it is the safest route. And then, of course, PrEP C is in combination with everything, right? It's not, Truvada is never to be used solo. As like, you can take Truvada, you don't have to do anything else. It is a toolbox, a tool in the toolbox, as we always say, and it comes with all of these other things too, and I think it's really important to stress that when we do the counseling sessions. And so just to talk about safer conception and what's happened over the years, as mentioned earlier, our clinic specializes in the prevention of mother-to-child transmission, and certainly that has been effective over the last 20 years. The decrease in transmission from positive moms to negative to their babies is really quite effective, less than 2%. I always quote about 1% if the mom is on heart therapy, then their risk of having a positive baby is about 1%. It really is quite effective if she's doing what she's doing. And so if you think about what prevention of mother-to-child transmission is, so the mom is taking antiretroviral therapy. So for the baby, that's PrEP. And then once the baby is born, the baby gets HIV meds or AZT, that's PEP. So you can see that we've been doing PrEP and PEP and these women for at least 20 or so years. And we have enough safety data where we feel comfortable in terms of outcomes for babies, long-term effects in moms and things like that. Well, those are ongoing, but certainly we have enough data to say what will Truvada do for women who take it who are not infected, right? And certainly Truvada is one of the newer antiretrovirals in the terms of MTCT. We've, in the years past, have really used Combivir, but we don't use Combivir anymore. I haven't used Combivir in years since Truvada probably has come out. Probably 100% of our women are on Truvada for MTCT. So anyway, great risk reduction with MTCT for ARV and mother. For the male that's positive, the goal to decrease male to female transmission using sperm washing and intrauterine insemination, IVF, for conception. Risk reduction is 100%, right? Because you're getting rid of all of the semen that contains the HIV virus, and so the risk to the mother is extremely low. This is extremely expensive. This probably costs about $20,000 to do, and so really is out of reach for a lot of our patients. Now, so what is in reach is limiting sex without condoms during peak fertility times, treatment as prevention for the infected partner, PrEP for the uninfected, treatment of STDs. And you can see the relative risk reduction in HIV infection, sex without condoms. Well, we don't know that here. This 96% is from the HPTN 052 results. PrEP, we talked about those results. And then if you just treat STIs and so that patients don't have syphilis or herpes or anything at the time of conception, maybe the risk reduction is down to 40%. So I think one of the most important things that we really need to know and understand is the risk to the HIV negative mother. And I can't stress this enough when I'm talking to negative women that have positive partners. When negative women are trying to conceive or are pregnant, they are at their highest risk of acquiring HIV. I mean, it is a scary situation to be in, to be either pregnant or trying to conceive with a positive partner. And so PrEP really gives you a little bit of peace of mind, but again, it's not 100%. And so for me, this discussion is an intense, deliberate discussion in terms of letting women know what their risk is. If you are negative now and you are trying to conceive, or you're already pregnant, your risk of getting HIV is much higher. And that's because of the cervical changes that happen during pregnancy. It permits the easy facilitation and transfer of the virus to the women. And if a woman seroconverts during pregnancy, this is the worst chance for the baby. This is the highest risk of when the baby transmits or the baby gets HIV infection, 8 times higher if mom seroconverts during pregnancy. And so that was the first case that I talked to you about, where this mom who was pregnant, she was negative initially during her initial pregnancy test, she was HIV negative. Somewhere during the pregnancy, she seroconverted, and then the baby became infected. And that's because with seroconversion, as you know, the viral load is sky high, right, gets up to over 1 million copies, and that's more risk of transmission from mom to baby, despite the maternal circulation and fetal circulations being separate. When you have such a high viral load like that, it's easier mixing and crossing of the blood in those situations. And so I think this is scary to talk about, and I think for us, we're really cautious when we counsel women on this, and I think it's important for providers to really understand this, and really to understand when you're talking about PrEP, it's not just, oh, just take PrEP. You know, really thinking about what is the risk to a negative person, particularly in this setting. So the way we do this, again, is our strategy is, you know, multifold. It's everything. Really, the partner has to be undetectable, right? We really, you know, work with him in terms of, and his provider, is he undetectable? We want him undetectable and sustained for a period of time. PrEP for her, are they both healthy? No opportunistic infections in the infected person, not using drugs or alcohol, because when you're using drugs or alcohol, you're less likely to take your meds, more likely to do riskier things in terms of your sexual activity, screen for STIs, and the safest option for becoming pregnant, so we avoid or limit condomless sex. So they can have as much sex as they want with the condom, not a problem, okay? But when it's time to conceive, that's when the condom comes off, if all of these things are done, okay? But again, stressing that nothing is 100% effective in doing these things, but the good chance of preventing transmission is really high if they do these combination of things. So again, like I mentioned, the safest method is the insemination, which most of our patients can't afford or have access to. Truvada is the only FDA-approved PrEP medication at this point that's listed in the guidelines for serodiscordant couples. Adherence is extremely crucial, like we talked about. And again, talking about the timing, how long do you need to take Truvada in this setting? When does it reach appropriate concentrations? And we know this from other studies that certainly in the cervical tissue, it takes about 20 days for it to reach appropriate concentrations here, and rectal tissue, 7 days. And so we want women to be on the Truvada for at least this long, if not longer, before attempting conception. And it's timed periovulatory unprotected intercourse. And I know that's a lot of words and sounds kind of crazy, but we tell our women to use, well, what is recommended in the guidelines is to either use ovulation kits, whatnot, and so you do all of these other things while you're waiting for you to ovulate, and then once you ovulate, you can have condomless sex in order to try to conceive. The other things that that's recommended in the guidelines and that some centers do is semen analysis, so that if there's a low sperm count, you're not continually trying to conceive because it's not likely to happen, yet you're putting this negative partner at risk. Okay, so some sites do sperm count as well. There was only one study. There's very limited information on conceiving or PrEP Truvada in conception. There was one study done in Switzerland that we do have data for. It's a very small study, 46 couples, and this protocol used similar to the guidelines in terms of combination heart therapy for the male with an undetectable viral load, but just used 2 doses of tenofovir at the peak LH level. So LH is luteinizing hormone. It can predict when you're going to ovulate, and so they give a dose then at peak, and then the second dose 24 hours after intercourse, and they saw no HIV infections and a high rate of pregnancy, 75% after 12 attempts or cycles at this. But again, this is a small study. More studies are needed to help drive or give us more information on what we need to be doing. If you looked at the Partners PrEP study, again, now Partners PrEP is the one where the heterosexual couples, serodiscordant couples, where the woman or the man, whoever it was in that group, took Truvada, but the person that was positive had no medications. So in this study, there were 267 women that got pregnant, and there were 288 pregnancies in this study. Now, as part of the study, they were not supposed to get pregnant, right? Like most studies that are treatment or prevention studies, you sign things that say you're going to use 2 forms of contraception and blah, blah, blah. But, we know how contraception works, particularly with condoms works, and there were pregnancies in this study. So with these women, they went back and looked at their adherence to see how adherent were they to Truvada the months prior to pregnancy. And you can see the adherence rate in this Partners PrEP study was actually pretty good for these women, and the adherence rate was detected by steady drug levels and pill count. So this at least was somewhat reassuring in that these women that did get pregnant, at least they were taking their Truvada for the most part. In PrEP trials, in general, we don't have long-term data, and that I think is the concern for lots of folks in terms of using Truvada or other meds that will come out for PrEP for conception and conceiving. There's just 1 to 4 years of data. Long-term safety is really not established for negative people. We do know from the IPREX study there's a decrease in bone marrow density, and these are things that we know about Truvada as it is, right? We know this from our HIV positive patients, that there's a decrease in bone mineral density with chronic use of Truvada. In the IPREX study, they did show that once the person stopped the Truvada, their bone mineral density returned back down to baseline after 6 months of being off of it. So that is at least good to know. But these were all men in this study. We also know that women are much more susceptible to bone loss. And so we need to be, concerned and worried about what the long-term effect of Truvada is, but at the same time knowing that, this happens over time. And those are the things that, the risk-benefit ratio is what we're going to have to consider when we're talking about Truvada, which is why it's important that these other PrEP agents are coming out in terms of the injectable cabotegravir, long-acting rilpivirine, and the monoclonal antibody, so that they're safer, or at least other agents that may not have such long-term consequences as Truvada may have for some people. I always get questions about breastfeeding for these women because remember, these women are negative, and women want to breastfeed their children. And so there is no contraindication for using PrEP during breastfeeding. And I also get asked, well, I'm worried about the Truvada or the tenofovir passing over to my kid, and then what's that effect going to be on the kid as well? And certainly for our HIV-positive women here in the United States, they don't breastfeed, right? So we don't worry about that. Certainly the babies get Truvada, or at least some of that passes through the placenta to them when they're born and whatnot, but they're not getting ongoing exposures with breast milk because our women don't breastfeed. But certainly if you look at these studies here, and this is again some of this comes from the Partners PrEP study and others, looking at the concentrations of tenofovir that's transferred in breast milk, and it's very small. It's only 3% of the maternal plasma concentration. So very little gets into the breast milk as well. The infant plasma level of tenofovir was unquantifiable in 94% of the samples at delivery time as well. And if you look at the total dose of exposure that a breastfed infant would have, it's really a small percentage of what I use to treat HIV-infected babies. So their amount that they get in terms of breastfeeding is extremely small. And these are some of the data that I share with the women that come to us when we're talking about PrEP. This is, again, more information from the Partners PrEP and those women that got pregnant in this study, looking at long-term or looking at delivery in terms of preterm delivery, pregnancy loss, or other anomalies to the baby. And you can see comparing the PrEP exposed to the PrEP unexposed that there really was no increase in poor birth outcomes in women that were exposed to PrEP. Okay, so it really is safe. And again, I stress that we know this already because we use it in our HIV-positive individuals, but you want to know this in HIV-negative individuals as well, right? Because positive women need to take this for their own health and life as well, and certainly as they are doing it for themselves when they are negative in terms of having a positive partner, they certainly are concerned about what the risk is to their child, whether it's during pregnancy or while they're breastfeeding. So the challenges in PrEP, of course, is the uptake for women. We have all this great data that shows it's great, 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 looks fantastic, we should use it. I say put it in the water in certain communities, but the uptake is not that great. And so if you look at the first quarter, certainly there was an increase comparing 2013 to 2016, and this is Gilead data showing the 72% increase in Truvada prescriptions for PrEP in women, but look at the dramatic increase in men, which is great, right? Because if you treat these men, or if men don't get infected, women don't get infected, right? Because men infect women, it's a heterosexual transmission for women. So certainly this is fantastic because we need to prevent the men from getting infected, but we need to see more women who are at risk, and I'll tell you about who these women are in a minute. Kaiser looked at their research, and this was presented at CROI last month as well, and they looked at all of the Truvada prescriptions. This is Northern California data, and so they looked at all the prescriptions from 2012 to 2014, 900 prescriptions of unique individual prescriptions, majority 98% men. So again, looking at who gets the prescription, certainly this is in line with the risk in terms of the epidemic as well, but where are 25% women here that are at risk and should be in here somewhere? Those factors that were associated with discontinuation, which I think is also really important information, if it was a woman, she was more likely to discontinue her medication. And again, I think this goes to educating women and knowing, are you at risk, and understanding what your risks are. And if you don't feel that you're at risk, why are you taking, for them, why am I taking a med if I really don't think I'm at risk, although someone maybe has recommended it for me too. Drug and alcohol use and co-pays are also a little bit more. But again, this big number of women discontinuing in this rate. And then, of course, our projects here in Los Angeles with DHSP-supported Centers of Excellence. This is fantastic in terms of the list of clinics that are enrolling patients for PrEP. And so for our cis females, there are 10 so far enrolled today and 12 transgender females. And so this breaks down the PrEP prescriptions in relationship to race. And I think this is an important slide to just kind of take a look at and really understand what's going on in terms of females. Certainly in males and the epidemic, you can see that, and this is from 2012 to 2015, you can see the males are in red here, and you can see the rise in prescriptions for Truvada for our males here. This is white, Hispanic, and so you see an increase, although certainly in terms of the epidemic, you would think that you would see bigger spikes in some of these other populations than you have here over the years. But what's interesting to me is the women. So look at the women in the blue. So you can see where the epidemic is hitting the hardest, these numbers are quite low here. And where the risk and lifetime risk of HIV is not as high, you can see the uptake of Truvada prescriptions is much higher. And African American women have 18 times the risk of white women, and you can see the uptake in the prescriptions for these women. Hispanic women are 4 times the risk of lifetime infections of white women, and again, you can see the disparities here. So this really points out where, we have work to do in terms of getting these numbers up and really educating women in on PrEP. So like I told you about some of our stories. We do pregnant women in serodiscordant relationships in terms of PrEP. And for us, the majority of patients that have been referred to us in the recent years, almost all of them were already pregnant by the time they came to us. And then they were referred for PrEP, after their pregnancy. Ideally, we like to do the preconception counseling. It's pre, so before conception happens. But majority, 100% of the women that we've had in the last 2 years have already been pregnant by the time they've come to us, which is fine. We take them then too, because certainly there is lots of discussion to have. Her risk is still extremely high because she's pregnant. So her risk of contracting HIV while she's pregnant is extremely high. Our non-pregnant women age range anywhere from 14 to 51, they're in either serodiscordant relationships or victims of commercial sex exploitation. We have partnerships with Juvenile Hall, our VIP clinic with services, women and children that have been affected by trauma. Our adolescent clinics, we do a lot of PrEP lecturing to our residents in those clinics. And then the county at USC has a new LGBTQ clinic that we also have partnered with and have written their protocol for PrEP for that clinic as well. So education is so important in terms of understanding PrEP and who's at risk. We educate in our clinic as well as outside. We recently participated in a documentary. 2 of our patients did Target Zero that will be coming out in May, and I think Rand Schrader also had patients participate in this Target Zero documentary, and it really is following 2 of our pregnant women, our HIV positive women, and this documentary is used to educate providers on HIV and try to help decrease stigma around HIV and what it means to be, for our patients, the 2 patients that participated, what it means to be HIV and pregnant. Okay, and they follow them from the beginning all the way to delivery of the baby. So, and it's great. I saw clips of it the other day and I was crying. It was beautiful. Hope to share that with you guys when it comes out. So what do we do and what are the next steps? For me, I think provider education, you cannot give enough provider education. Lots of providers out there are just not, they're unclear about PrEP, uncomfortable about PrEP, what to do, how do I give it, what do I follow? And so those of us that are in the know need to spread the knowledge that we have. The CDC did a survey, again, this was presented at CROI as well, and it looked at HIV providers, it looked at providers that see HIV positive patients and HIV negative patients to be in this survey. That's who they looked at. And this was from January 2013, 2014, they sent this survey out. And of those, only 26% had ever prescribed PrEP. And so, and these are providers that do HIV treatment. So if we're this low in terms of our PrEP prescription, you can imagine what the community providers may be like as well. Those that prescribed, they were consistent in terms of who they prescribed it with. Sorry, I keep on messing with this thing. Consistent with the epidemic, right? And so that looked good at least, but certainly the number of only 26% of people who work in the field prescribing PrEP is low. And they didn't go into what are the reasons why this was so low or not. We need to expand our LA County PrEP guidelines to include specifics on women. I think there's always confusion on what women should get PrEP. Do we just stick to the CDC? Who? Is it just the women that are involved in commercial sex, and are those with a positive partner? Who do we give? So we need to give our community partners and providers more specifics on women and how we're reaching out to women. And then, of course, we need to normalize talking about sex with their healthcare provider. Right? Providers need to be comfortable about talking about sex and sexual health, and the patients need to be comfortable with that as well. Biggest challenge is increasing women's awareness on PrEP. And certainly, we have to, if we increase providers' awareness, we will increase other women's in terms of their patients' awareness. But we also need to get the community and community stakeholders are very important in terms of the awareness of PrEP for women and the safety of PrEP and when to use. And increasing awareness will hopefully decrease stigma. We say that all the time, but I think there's still a lot of misconception about PrEP in women and who should be PrEP'd. And I also think that women don't know because they don't see the media attention given to them as well. Most of the social marketing and literature is targeting the extremely high-risk populations, which is appropriate, but we also need to target these subpopulations as well, because if women, like I mentioned in the previous studies earlier, if women are not aware they're at risk, they look at some of these marketing that's already out there and, oh, that's not me, and I don't need to look at that. So we really need to educate both women in terms of in the community and the community stakeholders, those people that are talking to our women. I think that is so key. Who are the influential people for these communities that we're trying to reach and get those stakeholders on board. I get a lot of questions when I talk about PrEP and women, and a lot of it, our questions are misinformation and why women shouldn't be taking PrEP and whatnot. So again, utilizing what we know from research and trying to dispel some of these misconceptions that are out there. We really have to address some of the factors that keep women from accessing PrEP, and whether it's stigma, intimate partner violence, immigration status in this day and age. I mean, these are all factors that may keep women from accessing services where they can receive PrEP. And again, normalizing sexual health. We need to increase the number of PrEP centers that focus on women's care. And so certainly we have the Centers of Excellence that is a fantastic start in terms of rollout in PrEP. Next step is Centers of Excellence that focus on women's care. Women tend to go to clinics that they feel comfortable in and that they frequent. They don't, they take care of their other family members, take care of themselves last. They tend to go to family planning clinics, so that's a good place to increase PrEP enrollment in. You need centers that provide testing, both provide HIV testing and treatment for HIV, I think in the beginning to help with the rollout, but again, helping and partnering with the family planning clinics with treatment centers is a good start. And again, these providers, at least for us at our LA County Medical Center, they're not offering PrEP yet in the family planning clinics, but they're interested in the discussions have begun in terms of how do you approach and who do you approach for PrEP in these clinics. Really important is partnering with research institutions to leverage private and public and private partnerships. And this is at all the university levels here in Los Angeles. There's private money, public money that we can meld together and meld our resources in order to tackle this issue. There's knowledge from demonstration projects, research studies. We need to get people involved in research so that we can understand some of these factors, understand different modalities that will work in certain populations and risk groups. We also need more help in understanding some of the social determinants of health that prevent people from accessing these services. Any questions? I know that was a mouthful.
Before we start taking questions for commissioners, I just want to remind the public that there are comment cards.